Hello YouTube, my name is Hans Christian. I live in Denmark, I'm 51 years old and I have Dupuytren's disease. In this video I want to share with you my journey with Dupuytren so far, also some of the considerations that I've been through. As a special bonus, you will get insight to a consultation I did with Dr. Professor Heinrich Seegenschmiedt out of Germany, who is treating Dupuytren with radiotherapy. So this is now 2020. I'm 51 years old, I live in Northern Europe, pretty normal life, I'm in good health, and I started to notice something 6 years ago, which were small noodles in my hand. I knew exactly what was coming for me at the time, as my mother, her mother and my uncle all have had this disease. And I also knew that the treatment that my mother had undergone wasn't that successful. My mother has been through both operation, needle therapy, and also being treated with flax, which is a consolation that kind of dissolves the cords. In research, you might also have found out that there's really only 4 viable options at the moment. One is surgery, one is needle acupuncture, one is the consolation injection with flax, and a more controversial one is the radiotherapy. A big disclaimer, I'm by no means a medical doctor, I'm only a patient, and to tell them about my journey. Before you do any treatments or make any decisions, go see your doctor, have a talk with him, but also be curious and ask the right questions. Dupuytren is a disease that is quite normal in Western Europe, also in the US and other places where you find a lot of Caucasian persons. For male in their 50s, in Denmark it is around 20% or even more that is affected by this disease. And for women, the status kind of is 10 years postponed. If you go up to people that is older than 70, 75 years of age, about 30 to 40% of the male population will have this disease. So it's quite normal to have it. However, the way the disease is affecting people's life is very different. It will depend on how severe the fingers are curled. There is a lot of information about Dupuytren on the internet. You probably have witnessed that already. These are some of my favorite resources. The Dupuytren Research Group I cannot recommend enough, especially Dr. Charles Eaton's work. I think he is a great communicator. He really explains what is going on and also is very good at separating facts from fiction. I would highly encourage you to see all of the 4 videos that I've linked to below. Also here you can see the video from Heinrich Seegenschmiedt that actually led me to get treated by him actually. So here's a bit about my considerations for my treatments. I knew my mother had had issues with the treatment she has received. She had relapse in all 3 cases. So the needle acupuncture, it didn't really work. It came back quickly again. The surgery also didn't work. It was quite painful for her. She had sore fingers for quite some time. And also when she did the flax or the consolation, that also came back with a vengeance. So none of those treatments that is quite popular was effective with her. That is not the same as they don't work. However, the way they work on the individual patient varies quite a lot. There seems to be evidence, that's what I have found out by looking at the foundation's research, that if your family have seen quite severe Dupuytren, like progression, then you are maybe up for the same. But there's no telling, and that's the frustration here. So a bit about my considerations. Bear in mind I'm not a medical doctor, so this is my own experience. Do your own research, by all means, and also consult a professional. What I wanted was 2 things. One, of course, I wanted to get rid of this, which is really, really hard. Secondly, I wanted to postpone the effects of Dupuytren, which is the curly fingers. Being a first-hand witness of how the treatments my family had undergone, especially my mother, I knew that I maybe should do something different. That a key issue is really that no treatments will cure you from Dupuytren. It will not treat the root cause because we don't know what the root cause is. But the treatments that is offered, they can be quite effective as to the effects of Dupuytren. So some persons will receive a treatment and they will be happy for the rest of their lives. Other persons will do treatments and they will see a full relapse within months. I think an issue when I did my research is that it's really hard to find statistics available that kind of give you insight into that how often the relapses are there. I've seen some studies kind of suggesting that 50% of all people receiving the Xiaflax injection will see relapse within a very short time, being even months, and that to me is just making no sense whatsoever. And I also think many of the sites where I've seen Dupuytren described does not fully show those relapse statistics. Again, statistics regards to Dupuytren is a funny thing, because if you have statistics, you kind of see, yeah, then you can start to predict stuff. The thing is, again, it's very, very, very tough, almost impossible to predict anything about the individual patient. When I looked at the research that Dr. Professor Heinrich Seegenschmiedt had done, I read both his papers and also saw some of the YouTube videos available where his research was presented. I thought that the case for radiotherapy was quite strong. I saw some quite good statistics on how much it actually postponed, and I thought that the professor actually was very, very transparent around his research, especially the numbers of patients that had been through, and also was very transparent around the success rate. And that actually gave me confidence in that was the way I wanted to go. So my treatment journey started with a visit to the Dr. Professor in Osnabrück, where he also have a small clinic that he's a part of. And the treatment itself was a 1 week treatment where I underwent the radiotherapy. And let's listen into the consultation itself, which I got permission to share with you guys. Look forward to show this to you. So this is the evening before my first appointment on the Strahlenklinik. Let me show you the state of my fingers as of today. So this is my left hand and this is my right hand. And you can actually see now that both the pinky fingers are a bit bent. Very clearly if I do like this, the fingers close together. And when I come to my pinky, you can see I cannot even join the joints here at all. If I should describe the sensation, it does actually irritate a small bit here. I need to scratch it from time to time, but there's definitely no pain at all. And here on this finger you can see some clear lumps, and definitely the progression has kind of taken up over the last couple of months. Even within weeks I start to see some slightly changes. So progression is definitely happening at the moment. But let's see tomorrow how things are when we go to see the professor himself.
So if you just go ahead, we will make your life on such a chart. Yeah.
Yeah.
We make decades. Yeah. And so Right now you're how many years now?
I'm 51 now.
So we have 20, 30, 40, 50, 60. So you're about here.
Yes.
Yeah? And here it's very simple. It's a 4-scale grade. This is the stage. Yeah? So you have stage 1,
Yeah.
2, 3, 4, and it refers to 45 degree, 90 degree, 135 degree, and 180 degree.
Yeah.
Beautiful. It's the scale for the surgeon.
Yes. Yeah.
I would need what I call the lupe. Yeah.
Yeah.
Because I'm much more interested in this part, which says, okay, 0 degree to 45 degree.
Yeah.
Yeah. This is a magnification of that stage.
Yes. I got it. Yeah.
And we say, okay, we have now here 51 years. Yeah, that's your situation. And you have a previous story.
Yes.
And your previous story starts in the mid here.
Yeah, that's true.
So this is the starting point.
Yeah.
And from there on, you are aware that you have the disease.
Yes.
But it could mean that it already here somewhere.
Yeah.
Yeah? So it could be somewhere here. We have a question mark.
Yes.
What you also have is genetics.
Mm-hmm.
Genetics. And that's just because you are the individual born out of a male and a female. Okay. And certainly your problem is related to your mother.
It is.
Your mother herself is born from a male and a female.
Yes.
Yeah.
I see.
And so it's your grandmother
Yeah.
who causes the problem.
Exactly.
Yeah. Okay. Now your mother may have siblings, and that's the uncle.
Yeah.
It's the uncle on her side.
Yeah.
So it's here the brother is affected. I don't know how many siblings she has.
He has 2.
So-
they're female.
They're also, but these females are unaffected.
We don't know yet. They're not that bit younger
So
than
we
me.
make a question
Yeah,
mark here,
exactly.
and another is,
No, that's the only 2. They have. She has 7 brothers and sisters in total.
okay. So
She's
you
the only-
yourself, do you have brothers and sisters?
Yes, my brother, and he has a small lump starting on his finger now.
So
He's 55.
So 55 years. So you may be the speedy among your among the group. Yeah.
exactly.
50 years, and you have a sister as well.
Yes, I have a sister. She's not
Okay.
affected. She's 38.
Okay, so the 38 question mark. Yeah?
Yes.
Okay, she may be just a transmitting.
Yeah, you
Person?
never know. We don't
Okay,
know.
so this is a highly positive situation. We say genetic risk. Yeah.
Mhm.
Not every situation in your family is a genetic risk, but if you have 3 generations being affected, usually that's the situation.
Yeah.
Okay, so this is the situation, but with a genetic risk, you could still be 70 and have no Dupuytrens.
Mhm.
What else should be done? You have what we call a trigger, and we don't know what is the trigger. Could be high active sports,
And it
volleyball,
was,
tennis.
I started there. I started rowing very intensively.
Okay, so it could
very
be
intensively. Yeah.
sports.
Yes.
Yeah?
And then I stopped the rowing for a couple of years, but I picked up muscle cardio, very heavy lifting, and then the progression started again.
So we could say rowing
Yeah. And then the weightlifting.
and weightlifting.
Yeah.
Yeah? Weights. Okay, this is your chart, and this is from Moslund. And every patient has an individual chart.
Yeah.
And you can develop it, and it's very plausible at the end, yeah? Because the
Mm.
disease in itself is not very plausible. So Hans, and this is with dash in
Yeah,
between.
I do that. I lived in Australia for a couple of years, and they could not get it if you didn't put a
Hans
dash in.
Christian, and the birth date is.
May.
So that's your
That's my chart.
chart, yeah? So chart number 1. In terms of prognosis, and this is the situation now starting 2020 to how old will you want to become?
I wanted to be 95
95.
in one day.
So let's
That's a wonderful
calculate.
birthday.
It's 2065. By that I'm 110 years.
Yeah,
So-
I'll come and visit you and
Dr.
celebrate.
Seegenschmidt is dead. Yeah. Still,
Maybe, you don't know. My maybe.
Still, I hope that if there is a graveyard, we don't know it, yeah, there will be still people walking by and putting small pebbles, tomatoes or oranges, because that's the consistency level of the nodules.
Yeah.
If you put a pebble on it, wonderfully scarred, maybe hurtful, but stop the disease.
Yes.
So, okay, so right now, I just look at your hands, on the other hand as well, and if you put them together, I always imagine this is a butterfly. The butterfly has two wings, and if you look at the texture of the wings, they're usually equal. Yeah?
Yeah.
So now look at you show me your butterflies, just show it to me right here, and we look at it. And what is interesting, every hand has a hillside and has rivers and creeks, and the same is due for yourself. Yeah, this means these are rivers ending in the, let's say, the Pacific, and this is down in the Indian Ocean. So whatever, they merge, and the end of your hand is usually right here. That's the end of the palm.
Yeah.
Yeah. So that's quite interesting. Now you spread your hands like this, and now again we watch the hand, and I will explain that it is quite different, because you see whitish discoloration, you see forms on the right hand which are not on the left hand, but also interesting, on the left hand you start to see whitish discoloration between the fourth and third, and if you spread more, you may even detect that there are differences between the interdigital spaces of 5 to 4, 4 to 3, 3 to 2. And even in 2 you see a whitish discoloration when you spread. And this is very suggestive of being affected by Dupuytren's with cords, small cords which run in there. There's also, just by visual examination, observation, I see there is some whitish discoloration in an area between the index finger and the thumb area. This is whitish, looks more thick than on this side. So just by visual exam, I can see there's difference. There's another important difference which can be seen. It's on the ocean line, because your ocean line here to the Pacific is quite different than on this side. What does it tell you? It tells you that, as you see here, if I spread, no changes. There are inner fibers who are pulled towards the palmar fascia. So this is a very simple observation without any palpation. I've seen a lot of things with your hand right away. Okay? And I would then start and say, put it flat on the, and I would say and prove that with a very simple testing that you are not fully tabletop. Here, I slip underneath this one, probably underneath this one, so you can try to push down. If you push down, I still be here.
Yes.
On the other hand, so both sides are affected, tabletop not complete, so you have D5 bilateral positive.
Yes.
Okay, this means you have already some distortion. Still, you might have compensation options. At the compensation option, you put the hand flat. Now you try to lift up the finger.
I can't.
You can't. Was it with this one? Okay, half a centimeter. We could measure this now. Get the full measure. You can do this at home. Do the same with this hand.
I can't lift it.
Okay, what is with this one?
Yes.
Okay, with this one. But it's, no, just keep it up as far as you can. And then you go with a measure and you just
measure it.
and you do it in your hotel and you give me all the values.
Yes.
Okay? The same is here, so it's much better. Okay. So we have D4 and D5. The extension test is positive. You can't do it. The others are negative, so you have more extension. The last test is what we are doing is we are now taking a piece of paper. Exam, I should wear my mask now.
Yes, that's fine.
You try to spread as much as possible and push down, okay? This is done, that we make a crusade. I call it the crusade in Norway, We just do the fjords. We started in Bergen, and we are ending up in the Oslo Sund. You still keep that hand as it is?
Keep it.
Okay. And then, because it was so beautiful, we start to do that a little bit more. This was the starting point. Okay. Left hand, we agree?
Yes.
Okay, now we lift up. And Now we turn it around. Are you a good?
On my right hand, yeah.
Yeah, just do it.
You're very, like.
Oh, that's too bumpy.
Yeah.
So we put it right here.
Yes.
I hold it. Okay. And now you spread as much as you can. Okay. And this is the affected hand. So, if you are a sailing person,
I have not sailed a lot.
but you are Danish.
Yeah, windsurfed a lot.
So,
That's a bit different.
this is the right hand.
Yes.
So, it's red color. Steuerbord. Okay? Just to make it more visible and later on for your community.
Yes.
Fine?
Yes.
Turn away. And now what you do, you look against the light and you get some feeling what is the differences in terms of spreading.
Yes.
Not too much, yeah?
Yeah.
But you're probably comparing an affected with an affected hand.
Yes.
You're not comparing with a normalized hand. Look.
Yeah, you can spread it.
Yeah.
Yeah, I can.
Not the same age.
Yes, but yeah.
Okay, but so just to keep it clear, this would be your green left side. Okay.
Yeah.
Now the point would be, you mark out the tips. The tips. Yeah. And you name it D1. Sorry, D1, D2, D4, D5.
Yes.
And with a ruler, and that's you do now in your hotel, you measure. Genau, ich bin gleich.
Okay,
you measure the values from here to here. You have a ruler with you in the hotel?
No.
I will give it to you.
Thank you.
And you just write your values.
Yes.
And you need this again. So what does it mean? It is your template for the future. With this template, for the next 5 to 10 years, you can have yourself an objective measurement of how your hand changes.
Interesting.
It looks so simple, but it's a very important tool. And even with that, you can also put your values, how much you can lift up your fingers.
Yes.
Yeah. This makes many things much more objective and clear.
Very good.
So D1. Okay?
Very good.
So this is the right side. And so all findings become more objective.
Yes.
What is also important, you can see fifth and fourth finger are very tight together. On this hand it's not.
Yeah.
Yeah?
Yeah.
Especially if you spread.
Yes.
So consider the butterfly situation, your wings are different.
Yes.
Okay. With this testing, functional testing, there's another last exercise. Try to get your thumb like 90 degree. Can you get a 90-degree angle? Not really. If you look at your hand, it's almost on the left, on the right.
Yeah, it's not.
It's 85. Yeah. This is 85. So we write on the right hand about 90 degree. Yeah.
Yes.
This is this angle, and on the right side you have about 85 degree.
Yes.
Again, a certain difference of 5 degrees.
Yeah.
Okay. Question is, how often you should do it? Every 3 months.
Okay.
That makes sense.
Yeah.
We have 4 values because any other consideration makes you getting nervous. Yeah?
Yeah.
Don't write a diary.
I don't know.
Okay. Put this aside. I will document this in your chart.
Very good.
And now, having the situation after I'm doing the examination, you are still in a situation which I would call stage N. Yeah? Despite the fact that your hand are still, you have a little leg here, maybe that's 10 degree. So let's say these 10 degree is exactly this change between N and N1. And for the radiation therapist, the 10 degree are an important line. We still have a line at 30 degree, but the prognosis drops with the degree which you have already being affected.
Yeah.
With 0, certainly we are talking about 85 to 90%, 10-year stable situation.
Okay.
Here we are 75 to 80%, and here it drops down to 50. Yeah.
Yes.
To probably 60%. Still 50% in that situation is not a bad result, but you can't expect that function will improve with radiation. It's always stop.
Yeah.
Stop at the level. And the 30 line is insofar important as with 30 lines, this is surgery.
Yeah.
Yeah? Or SX could be the open,
Yeah.
but it could be also flexible, CFlex. At that level, the area of the surgeon starts to be making sense. In
Yeah.
that area, he may even induce a further progression of the disease.
Yeah.
That's why they don't touch that area.
Yeah.
For radiation therapy, this field is probably clearly defined as being the best to do for that type of disease stage. Yeah? No surgeon can ever do the same as we can do with our radiotherapy. Yeah?
Yes.
Treatment. We also cover the whole critical area. This is an important advantage. If you do an injection, the injection will just affect one nodule.
Yeah.
If you have 5 nodules, 5 injections,
Yeah.
very expensive
Yeah.
game. So you could take corticosteroids. However, if you take corticosteroids,
Yeah.
how much risk you take for your system,
Exactly.
for your body.
Yeah.
So this is very clear cut to the palmar fascia where it occurs. So just that's for the prognostic area. So depending on the angulation, you have a better or poorer prognosis. Now for the exam, so we are starting with, let's say, this is the more affected hand.
Yes.
So I usually start with the unaffected or the less affected hand. By doing this, I put the hand and I go alongside the ray coming from the source point down here, and I try to feel what is the bumpy road on here. And I can feel that you have already here nodule coming close to the digital joint. The same is here. And now we are getting into the problem of how to sign, and I have different pencils prepared. But it's clear that if you overstretch, you can also see that there is some whitish discoloration showing up here and here. The same now is the question, is this callus formation or is it a nodule?
Yeah.
It is some callus formation, but underneath there is also some sort of nodule. This is callus formation, yeah, probably due to weightlifting. The question is, do you have a nodule? Yes, you have a small nodule underneath here. Question, do you have cords here? I don't feel some. Now you see, if I overstretch the whitish discoloration, this means the skin and the underlying fascias are somehow tied together. Yeah? And this is a sign of pathological in the usual inclusion, and then you feel here nodule area in this area. Question is, this looks like a cord. Now again, I lose because you are moisturizing skin.
Yeah.
This will become drier, so it will become easier in the end. So, but just do the same coloring. With this blue, it's better. Okay, and again here. Now we're coming to that point, and again, as you see, you have a cord running from here to the thumb area. You're not playing piano or whatever?
No.
Because this is the anchor point, and somehow you can see that it enters into the thumb area as well. Yeah? Okay. So this is the hand which you thought is less affected, but it is already affected. Yeah. Now, with regard to the finger, you have in this finger, in the what we call the pip joint, let's say 5-degree angulation.
Yeah.
Yeah. Okay. Let's do the other hand. For comparison, it looks like, even from the consistency, to be harder. These nodules are more, and the grades are tomato, orange, tennis ball, coconut. This is a tennis ball already. Yeah. So this is grade 3, and it's already attached together. If you think the puffiness would be a nodule, that's wrong. It's like a balloon lifted up between two narrowing areas, and then if you palpate, you feel another nodule coming along here, and you feel also a cord running into this area. Next situation here, this is not only callus, this is nodule formation, and you have also here some tight fibers which are between the fingers, and if you see here, they become whitish. Now I'm looking for nodules in this area. There is a soft one here. If it's soft, I not only make a full circle around it. Don't be so, some elasticity, okay. Then it's sometimes easier to, and then the big question is, does it extend? Yes, there is another part here. So you have what we call, beside the palmar affection, also the digital. And this is very prone to become a claw-like development. Yeah? Because this will pull together and will pull the hand in the long run in the wrong direction. Now on this hand, apparently the cord is much less evolved. Yeah? You wonder, but it's on the other hand, it's more evolved. I can go perpendicular, I still feel the cord, but it's not enough made that I say, okay, so I just make little dots on it. Yeah, that's your situation on that hand. Okay, so with regard to treatment, if you consider the palmar fascia being usually in this part, and it tends into the skin, so this is palmar fascia, usually running into that area. You have a special part here, a special part here. Then it becomes clear that we need to irradiate from the root here. We avoid that part, we have sufficient safety margin. I don't treat here, but in here you have to sufficient margin up to that level. And that's the situation just from the anatomy plus the nodules plus safety margin. In the first round we try to be as, this is very close to the digital, but here that's about what we can do. Now with this type of situation I have to look up for my matching foil, which is a foil representing this, or I can just measure it. And so the measurements say from 1 to here it will be 12 centimeters. Yeah, 12 centimeter here, 12 centimeter, and this is a 45-degree angle. So we have exactly that type of cutout prepared in lead. It will be put into the beam, which has a rectangular field. And again, if I measure this, 12 centimeter. So this is from us ideal, but it's a normal situation. If your fingers would not be involved, you would have a 10 centimeter. So depending on the involvement of the finger, this cutout is 10 or 12 centimeters. Yeah. And that can be planned now. So easy. Now for documentation, we need to make photographs. And we take the photograph. So Mr. Moslund, this is now the formal informed consent. After we have talked, have examined you, this is the documents we have to sign, and it gives us an exemption from doing damage to you, radiation damage. So in general, these are 2 RT series, and they are separated by at least 12 weeks. This is due to the fact that we want that the skin after the first series repairs 2 times, and you have a very full new skin when you start your second series. Yes. There are other concepts they're doing it 4 or 6 weeks. We are not supporting that approach. So that would mean that you would come back in November, earliest, for your second series. Yeah. The series itself consists of 5 treatments. Should be within 10 days, so not strongly starting on a Monday, but they could start on a Tuesday and end on a Monday whatsoever. Yeah. But within a week, usually that's the concept. Up to 15 gray. First series. Then followed by the second series, and then full dose being 30 gray. Usually we address the fingers which are affected and the different nodules. We are not addressing the thumb, we are not addressing the wrist, and so you get this type of trapezoid shaped field. Yeah. which is a cutout which is placed into the machine itself, and your hand shines through. We make documentation, plus 0.5 centimeter bolus. This is to limit the penetration depth, let's say usually 2 centimeters to 1.5 centimeters. Yes. In terms of which side effects, you might have dryness, and so I show it because your sweat glands will produce less moisture. In the long run, people who have dry skin may suffer from it, and they need to get ointments, creams every evening in the night. That's what I'm usually preparing. The lotion I recommend is usually XCPI Lipo Lotion with about 4% urea. Also contains lipophilic agents and making your skin smooth. If you use it in the evening, then you don't have any contact, you don't remove it. If you would have pain, pain could increase somewhat, but you have no pain, so I don't expect to have it. Unless the nodules become harder. And if they become harder, some people interpret this as a progression, but this indeed is a scarring. It's a concentration, and sometimes pain may be due to the pressure point being or coming up at area. So tomatoes and oranges may become softer. If you have already tennis balls, they may become harder. So it's a matter of story and history of the nodules. The longer they are, the harder they become. And radiation induced to make them harder, to get all the scarring effects. There is the question of can you have sexual contact if there is any limitation? No problem for the whole body. The whole body is half a meter away, so all the organs don't get any radiation. The question is with regard to possible induction of cancer. And for a person like you, beyond 50, we usually say within 30 years, so this is within reach, we may have 0.5%.
I saw that.
That's the rate which is calculated. And aim. Aim is stop. Stop at the level existing. So first of all, second, preserve function. Preserve function, and stop and preserve function about, since you're in the N10 degree, so it's in the level of 75 to 80%. So it's not as good as you would have come earlier. So third aim is avoid surgery. This is not good for the hand surgeons in Denmark, but it's good for the patients. Because we follow the same rules. Preserve for the patient and not restore. Preserve a house is better than to restore it. It's cheaper, it's earlier, it's nicer, and that's how we feel. And we are not competitors. We are actually not overlapping. So we are adding to each other. That's the important part. So the concurrency comes from the fact that we may treat patients who don't need radiation, or that we treat patients who should get surgery. And that can be false, and I usually consider the limit at 30-degree angulation, that surgical field. So that is now Dupuytren, not Lederhose. For Lederhose we say wait and see. Follow up, very important, would be radiotherapy first series, second series. This is August, this is November 2020. I would like to see you in February for first follow-up, which is required in Germany for acute, so 3 months. And I would see you a second time for follow-up, exactly November 2021. Because this is 12 months. From these 2 points, it's a very good prognosis can be taken for the rest of the next 3 and 5 years, so third year and fifth year. And from there on, we just communicate via internet or by follow-up.
So this is now the last part of the video, and this part of the video is actually made a month and a half after the first part, and actually 2 weeks before I have to leave again for Osnabrück to do the second series of the radiotherapy. I can say that the first treatment has been, I would guess, successful. I had no pain. It was very easy. It was just 5 days. It took 10 minutes per day. You can see some pictures here how the scenario actually looks like. I stayed in wonderful Osnabrück the whole week. So I would say that was a good experience. The second treatment will be no different. It will be 5 days, Monday to Friday, 5 to 10 minutes with the wonderful people at the clinic. So and a brief consultation with the doctor professor as well. Before I end up with this video, I wanted to talk about two things. One is the cost of the treatment, and one is when to get the treatment. I would say the cost I would not share with you guys, because I think that is the discretion of the clinic. Though I will say the following. I was very pleasant surprised with the cost. It was definitely lower than I feared. I had to pay this out of my own pocket because this is treatment abroad, so it's not covered by the Danish government. I've seen what people are paying in the US and also in the UK to do these kind of treatments, and the cost here was a fraction of what I've seen quoted. So if you live in the US, I would highly recommend, if you are facing a very large quote, contact the clinic, get a quote. I don't get anything out of saying this, but there should be definitely good gains. So when is radiotherapy justified? And Professor Heinrich Seegenschmiedt actually shared this chart with me. If you have 3 of the 6 conditions that you can see here on the slide, and please read through them yourself, well then you can say that Dupuytren is progressing and radiotherapy is justified. However, if your fingers have been too much, and you can see that earlier in the video and also here, don't go for it. It's too late. You need to do this a bit earlier, I guess. But get advice. All this has been a pleasant surprise. I'm very, very happy. I have seen no progression since the first treatment. That might be luck and nothing to do with the radiotherapy. It might have everything to do with the therapy. There's no telling at the moment. Maybe I should make a new video in 5 years from now. With that said, feel free to reach out to me if you have any questions or comment in the video, as well, and share your own experiences, and by all means join the Facebook groups around Dupuytren to get the latest and the greatest in this field, and also to gain support from others with this disease, and also share your own support. Thank you for listening in. This was quite a long video. Hope it was worth your time. Stay safe and stay cool.